Good evening. It's Dr. Soloway on Friday, March 1st, and it's Dr. Steve TV tonight. Thank you, John Monero, for the tip on what to call it. Anyway, I don't want to waste anyone's time. I have a great case. I thought I was going to be presenting this case a little bit later. It's a guy that I saw 2 weeks ago, and his data came back today. So I'm going to tell you about his case. So I'm going to be reading off my computer so I don't miss anything, okay? So a 25-year-old white male was diagnosed with pleurisy in 2018, successfully treated with NSAIDs. 1 month later, he developed pain in all PIPs and all MCPs with prolonged morning stiffness. In November, he developed a flu-like syndrome with fever and chills and loss of appetite. He documented that he had a fever every night to 102, which came to normal within a few hours, and he had no other fevers, no other spikes, and never had a fever that did not spike to less than 102, and never had a spike that did not return to normal. At this point, you should all be having certain thoughts about the case. He brought some data with him that had been obtained at the hospital several months prior to me seeing him for the first time, and I saw him for the first time on February 11th. He brought with him lab data that was about a month old. He had a white count of 3.6. At that time, somebody placed him on prednisone 10 milligrams. Okay, let's see. At the time, he was 5'6". He weighed 155 pounds for a BMI of 25. His pulse was 132, blood pressure 114/79. His pertinent review of systems for positives only: chills, night sweats, nausea, weight loss, fever, fatigue, weakness, and a recent illness, joint swelling, morning stiffness, tender joints, and joint pain. Physical exam: synovitis of the PIPs and MCPs bilaterally, no hepatosplenomegaly, tachycardic at 120. Nothing else on exam. Okay, so this was my thought process after seeing this gentleman. So I can read you my thoughts, and I grant you that they're probably a little bit short for a complete differential diagnosis. But anyway, after I saw this gentleman, I wrote that he is suffering from a multi-organ disease that started with pleurisy, now led to what sounds like inflammatory pneumonitis and possibly myocarditis. And I based the myocarditis at the time on tachycardia. I believed he had tachycardia from myocarditis based on the history I had had. Later you'll see that that changes. He had a low normal white blood count. He had a quotidian fever pattern and significant constitutionality, and of course inflammatory polyarthritis. At that point, my differential diagnosis included adult onset Still's disease with a typical fever pattern, although no rash had been noted, and other conditions that I have listed here include lupus, cryoglobulinemia, sarcoidosis, lymphoma, rheumatoid arthritis, IgG4-related disease, and there are many other things in the differential diagnosis, and I am completely aware of that. However, common things occur commonly, and sometimes you just can't check for everything, or in a busy private practice, you can't list every single solitary differential diagnostic possibility. Anyway, blood work was ordered. A CT of his chest was ordered. And I did start him on prednisone 60 milligrams. Okay, so today his lab data came through. And it should be noted that because he was not well, 5 days after his visit, he was called by my office at my request to check on how he was doing. And with 60 milligrams of prednisone, he had no further chest pain. He had no fevers, and he had no further joint pain whatsoever. Okay, so here's what I have in terms of his lab data. So first, there were a couple of things that threw me off, and part of his differential diagnosis that I didn't mention were infectious diseases. So it should be noted, and I think this is kind of interesting, that his Lyme ELISA was positive, his Western blot was negative, his Parvo IgG was strongly positive, his Ehrlichiosis IgG was strongly positive, his babesiosis IgG was strongly positive, all indicative of past infections. So that may have thrown a curveball at you, but here's where the meat of the action comes in. White blood count 1.7, lymphocytes 644, sodium 134, potassium 4.0, chloride 97, CO2 24, glucose normal, GFR greater than 100. BUN and creatinine were completely normal. Liver functions were completely normal. His CRP was 17, which is significantly elevated. His ferritin is 676, which is also significantly elevated. His iron saturation was 8%. His C3 was 51, which is quite low. His C4 is 6, which is quite low. His CH50 is 18, which is quite low. His albumin is 2.9, and his serum protein electrophoresis is consistent with an acute phase reactant. Okay, I am leading you down a path. I'm giving you these results in order for a reason. I mentioned the chemistry panel. Don't forget, 134 on the sodium, 97 on the chloride. His CPK is 15. His thyroid functions were normal. Okay. His CCP antibody is 51. All right, so now you should be formulating yet another differential diagnosis. White count 1.7, lymphocyte 729. Again, that lends to a lot of things. I should mention that I did mention I ordered a CT of his chest. He did have a left pleural effusion, and he did have a pericardial effusion. His urinalysis did show proteinuria. Okay. Are we getting ready now? The big tests are coming. Okay, his testosterone's 148, clearly low and probably indicative of his chronic disease, but nonetheless, I'm still trying to hold out on you. I already mentioned elevated CRP and ESR. Okay, ANA, 640 speckled pattern, Coombs test positive, Smith antibody greater than 8, SSA and SSB negative, double-stranded DNA. Okay, hope you're sitting down. Nearly 7,000. Okay, nearly 7,000. And remember, his CCP was 51. His rheumatoid factor was negative. Okay, so we've got a guy with lupus, polyserositis, polyarthritis, proteinuria. I mentioned before I thought he might have myocarditis. He did have pericarditis, we know that for certain. And now the reason I believe he was tachycardic was with his sodium and chloride that were both significantly low, and knowing that his CPK is only 15, I suspect he was sicker longer than I thought, and I do suspect that his probable intravascular dehydration along with his anemia and iron deficiency excuse me would explain his tachycardia. He's due to be seen in the office on Monday. We called him today and told him his results. He will be having a 24-hour urine protein collection. If the results are 2 or 3 times the upper limit of normal for 24 hours, he will be getting a kidney biopsy. He will be placed on Plaquenil. He will be probably placed on Cellcept. For the polyarthritis, I will likely use methotrexate. And his steroids will be weaned. I will never order his ANA again. I will likely order his DNA once a year. I will likely order his complements 1 or 2 times per year. I will follow his lymphocytes. I will follow his white blood count. All although his iron deficiency needs to be addressed, the Coombs test being positive, he will need an evaluation for hemolysis, and I will repeat his acute phase reactants probably one time just to make sure everything did what it was supposed to. He will see an endocrinologist or a urologist for his low testosterone. And okay, so this was a great case that I thought was going to present and act and become adult onset Still's disease. However, this patient clearly has lupus. Now, for interest, adult onset Still's disease typically presents with negative ANA and negative rheumatoid factor. But clearly the quotidian fever pattern, I haven't looked it up, but I'm not aware that it occurs in lupus. In fact, if this patient ended up having a quotidian fever pattern, one could make an argument that he also did have true features of Still's, and perhaps there is some overlap. Was not concerned about the CCP. Okay, I hope you enjoyed the case of the week, and have a great day.